quickly about tracheostomy safety when you encounter a patient or you're called to the bedside with a patient who's got a trach that's either out or dislodged. Okay, so it's kind of just to talk about the approach and then a few techniques that can spare a patient from getting a false lumen, which is the most common complication of reinserting a tracheostomy that's fallen out. Okay, so I would say that the first thing to do is when you encounter this sort of situation is not to panic. Okay, the vast majority of folks who get decannulated or self-decannulate or it falls out are folks who are not on the vent and who are on trach collar already and are relatively stable from an oxygenation standpoint, usually. Okay. So those trachs are usually deflated, the cuff is not up, and they're already breathing through their nose and their mouth and around the trach. So there's no reason to panic and go and shove the trach back in. So take a step back, take a deep breath, look at the vitals, ensure that the patient is stable, and whatever you need to do to kind of stabilize the patient first, whether it be positioning, suctioning, do that first. And then kind of collect yourself, and then the next step to do is to figure out, is this a new trach or an old trach? Okay, we'll talk about old trachs first. So old trachs are defined as trachs that have been in place for over 2 weeks, roughly. Okay, so we'll use 2 weeks as kind of our cutoff. So a lot of folks we see on the floors are folks that have come in with a trach or have had a trach for a month. Okay, those tracks are formed and they're mature, which means the likelihood that you can do serious damage is less. Doesn't mean you can't do it, but it's less. So in those folks, I would still notify the provider, and in that case, if you're on the floor, it's going to be the APP. If you're here, it's going to be the APP, and you come up with a plan together, okay? So basically, you're going to get help. You're going to position the patient appropriately, which in most cases is going to be extending the neck. When patients are slumped over like this, don't try to raise their head and stuff the trach in. What happens is it hits the posterior wall, and you end up with a false trach, okay, or a false lumen. You can even go through and go into the esophagus, which would be very bad. So you want to lay them flat, you want to suction them well, you can put a non-rebreather or anything you need kind of over the stoma, over their mouth. You want to give them reassurance and then hyperextend their neck. Okay, you're going to always and always and always put an obturator in. Don't ever try to put a trach back into a stoma without an obturator. And the reason for that is if you feel the edge of this, it is very sharp. Okay, these edges are super sharp and can easily tear through tissue and create a false trach. Okay, so you're going to put the obturator in, and then a trach that's going to go in without issue is going to go in on its first try, and it's essentially going to fall into the tract. I mean, you are not going to need to use force at all. If you meet resistance, the rule is do not force it. Do not manipulate it. Do not try to turn it. Don't do anything. If you guys meet resistance to protect yourselves, pull the trach out just to the point at which you meet resistance, so you keep the stoma open, notify a provider. We will get there. We will do what needs to be done. Okay? When we try to force trachs in with resistance, that's when we end up with problems, even if it has an obturator. Okay? Does that make sense? Any questions about that? You guys understand the tracheal kind of anatomy? The stoma is basically that soft tissue, the tunnel that we go from the external part into the airway right here, right? False trachs can get made in this area and in this area right here, okay? Always, if you have issues with the tracheostomy and you have resistance to bagging, sometimes tissue might be stuck in the inner cannula or around the actual tube, so always look to see if there's tissue inside or stuck to the edge. Sometimes you can get like a flap type thing when the patient, and a patient can create that just from moving up and down like their head. It could dig into the soft tissue and create kind of a little valve type thing. And so that can also cause problems if you're having issues bagging a patient. Talking about new trachs is anything inside of 2 weeks, basically. Okay, we have a lot of them, right? This week alone, we're going to have 4 or 5 new trachs on this unit, right? So those folks, again, most cases, they're getting a trach because they're not very strong and they're not going to be decannulating. They're on the vent. They haven't been liberated yet. So in most cases, those trachs are going to stay put. But if you do come across a situation, and it does happen, it happened earlier this week, where there was a new trach, but it's been dislodged, coughed out, whatever it may be. Same rules apply. Assess the situation, assess if the patient's stable. There's no rush. There is no rush whatsoever. These folks can always be intubated from above, okay? So don't treat this as a true emergency, okay? This needs to be dealt with, but there is no rush. You're not gonna, if this patient is crashing, you're not gonna try to put the trach back in. You're gonna intubate the patient from above, end of story. If the stoma closes, the stoma closes. We'll deal with that, okay? Just patient safety and oxygenation ventilation is primary, all right? So new trach, you guys should not be trying to even put it back in, okay? New trach is notify the provider, okay? And then they're gonna escalate it. Because a new trach, by our policy, attending's gonna come in and put that trach back in through a bronchoscope. So we can 100% know direct visualization during the procedure, okay? Don't underestimate how easy and how common it is to create a false lumen and the trouble that can lead to. Okay, so very, very easy. Any questions about any of that? Does that kind of make sense? Okay. And all of this is really more to kind of give you guys just a little bit of an approach to not panicking and trying to knee-jerk reaction, put it in, and then to just protect the team, right? I don't want you guys in the firing line if you do something bad, right? We're not telling you not to act, we're telling you just act smart and always escalate and always document, okay? Make sense?
Yes, sir.
Any questions at all? All right, cool.
Thank you.
Great, thank you.